Okay, Steve, this is the debrief for novice clinician phase fortnight 3 simulation 1, or your second simulation of the day. Just run me through, what did you have, what was wrong with the patient?
Yeah, so a male with a stab wound to the right side of his abdomen who was hemodynamically unstable and then trended down into cardiac arrest.
Yep, great. Your management for him?
Yeah, so I think initial management was to check whether there's any sort of life-threatening hemorrhage that we can amend with either tourniquet or direct pressure packing on wounds, which the abdomen wasn't. After we've done our check for other catastrophic hemorrhage, it was like, let's not muck around on scene and prioritise expedited transport, and then do everything on the run, so maintain his oxygenation, gain IV access on the way, try to keep him permissively hypotensive, and then keep him warm to prevent any worsening of hypothermia, which may lead to acidosis and further worsening of acidosis and coagulopathy.
Yeah.
So,
and then
yeah, rule out any other sort of serious causes of the hypotension which we may have initially overlooked, such as a tension pneumothorax.
Yeah.
Yeah.
And so then obviously patients deteriorated.
Yeah.
I think you, as we were saying, you had TXA starting to go.
Yeah.
You had fluids going in.
Yeah.
And yeah, patient has arrested. Thoughts from like your management from that point?
Yeah, so I was sharing my mental model with AD, but I thought this is a traumatic event, so I was putting it on being probably potentially two H's and two T's, being hypovolemia and hypoxia, which we were doing our best to correct on the run through fluid resuscitation, as well as ventilating the patient with an I-gel. Tension, there was no hard signs of tension prior to him arresting, so tension unlikely, but I thought if he remains in cardiac arrest, I think it's definitely, I think you could argue that he should be decompressed to exclude that, and then tamponade, which I can't do anything about, but we had Haru that we're meeting on route, so they can do a resuscitative resuscitative a clamshell thoracotomy on this patient.
Yeah. Great. So that's going to be my next question anyway. Give me your justification for your management, but you've done that as you discussed your management. Anything you would have done differently or changed?
Yeah, it's always that balance in your head. Like I initially noticed that he was poorly perfused, and most likely from the hypovolemia, from the ongoing hemorrhage. So my management was probably tailored to trying to correct that first, but then it did take a little bit of time to sort of get that rolling with the ambulance. But then I'm like, well, I was seeing his blood pressure trend down, and I was like, well, I haven't done a good thorough respiratory assessment to exclude tension. But so I think that I was probably justified with trying to hop on just because of the location of the stab wound and how the patient was presenting initially. I think that I was probably justified trying to get on top of the circulation first before going back to breathing. Yeah. Just through the pattern of injury. However, I think if the stab wound had been higher, I think I probably would have been just as justified to, do a good thorough B assessment, rule out the potential for a tension pneumothorax prior to getting on top of C, but I don't think I would have changed that in retrospect.
Yep. Yeah, absolutely. And like you said, the location of that stab wound can't necessarily just if you disregard what angles you've been stabbed at, how fast the blade got in, but I think appropriate justification for not just immediately sticking needles in his chest, or becoming hyperfixated or suspecting that that's the primary issue.
And I think at the end of the day, we weren't seeing any like definitive hard signs of tension with the unilateral chest wall movement, you know, subcut emphysema, and things like that. So I think if probably they were there, I definitely, you know, would get on that as put that higher in my priority. But in trying to get on top of his perfusion was number one, my priority.
Yeah.
Yeah.
Great. Well, mate, I think overall you did a great job. I think it's just that forward momentum, hey, we need to like see if we can arrest this hemorrhage to whatever degree we can, but we know it's bleeding internally, right? So it's, you know, quick sweep for what else is potentially there. You've identified that there's just that one isolated stab wound. You've done a quick bandage, bed's out, he's on the bed, and you're moving. And so a lot of stuff was happening. Patient obviously was always going to deteriorate. Thoughts about inotropes?
Yeah, like it did. He deteriorated very quickly, and at the end of the day, we lost him pretty quick. But I think it just would have delayed the inevitable, and it's not correcting the reversible cause. I definitely think that there is a place for them, but I don't think he would have survived.
Yeah.
I think it would have been just a temporary measure for.
Yeah, absolutely.
You know.
So I can tell you how this in what the thinking was. If you had chosen, say you in the back, you'd chosen to give him some small lots of adrenaline or try and place him on infusion, it would have bought you maybe an extra 2 minutes before the patient arrested anyway. And for all of the reasons that you say, and yeah. I mean, don't make any blanket statements. It's obviously case dependent, and location dependent, and all this kind of stuff. And you're trying to buy more time down the road here, or a minute out from the Royal, where the surgeon's waiting to run up with you to the bed. But I think that's all reasonable justification. I liked your management, you're in control, communication was clear, you were thinking about the warming, you had the TXA going. The only thing I would say is once the patient arrested, you're fairly confident, right, that like this is due to hypervolemia. I probably would have considered maybe just putting in a quick humeral head IO. Oh yeah. And just start a second bag before you start the compressions, especially when there's only 2 sets of hands. If that's what you think the cause is. I mean, this guy's we know he's cactus, right? Yeah. You're not even you're not at hospital yet. Yeah. If you've got this uncontrolled internal hemorrhage, unfortunately, whether or not you've got another bag running at the same time. Yeah. Is it going to make a difference? Is it going to change the outcome?
I think that guy's best chance is maybe Haru to open him up and see if they can control whatever.
And potentially.
Light him up some blood products.
Yeah. So I guess that would be my only thing. It's okay, if this is what I think is going on, I'm just gonna before I can commit to the compressions, let's see if we can give it a little bit more volume, or at least get it running, and then we can start. But mate, other than that, it's good. Cool. Good handover to Haru. Yeah.
Sweet.
Great. That's all I was saying. I think that's Jack's. We had a chat. That's Jack's thoughts as well. So.